So our fourth and final speaker for the session is Dr. Janet Lee. She did her surgical and colon and rectal surgical training here. Also, thank you, Janet, for co-directing the course. She's going to be speaking about diagnosis and management of low anterior resection syndrome.
So let's say you have a 72-year-old female with a T3N1 rectal cancer, 7 centimeters from the anal verge. She undergoes neoadjuvant chemoradiation. Then you do a robotic low anterior resection with diverting loop ileostomy. She undergoes adjuvant chemotherapy after that, and after her chemotherapy is completed, you wait a month and reverse her ileostomy. You see her 1 month after her ileostomy reversal, and she's having 8 to 10 bowel movements a day, fecal urgency, and clustering of stools. You have her come back 6 months later. She's improved slightly, 6 to 8 bowel movements a day, fecal urgency, and difficulty evacuating. Does she have Lars? What are her risk factors? What can the patient expect for the future, and what are her treatment options? We'll be talking about low anterior resection syndrome, discussing how to diagnose or measure Lars, ways to reduce the risk of Lars, treatment strategies, answer these questions from our case, and end with a brief summary. So what is low anterior resection syndrome, or Lars? This is impaired bowel function after a low anterior resection affecting one's quality of life. Up to 80% of patients with proctectomy can be affected, and there's a high correlation between decreasing quality of life and severity of Lars. The most common symptoms are fecal incontinence, stool frequency, flatus incontinence, urgency, and use of a pad. Oftentimes people will have the sensation of incomplete evacuation, constipation. They can have any combination of symptoms and may also have associated sexual or urinary dysfunction. In general, most patients can improve over 6 to 12 months postoperatively, but symptoms can persist as late as 15 years in 50% of patients. The etiology of Lars is unclear. Some think it may be related to damage to the internal anal sphincter from surgery or transanal stapler insertion, changes in the internal anal sphincter pressure, a decrease in the anal canal sensation, or reduction in the rectal reservoir capacity and compliance. There are two main tools that we use to measure severity of Lars. One is the Memorial Sloan-Kettering Cancer Center Bowel Function Instrument, and one is the Low Anterior Resection Syndrome Score. So the first instrument is 18 questions based on 3 subscales, mostly looking at frequency, diet, urgency, and soiling, with some other miscellaneous items. It's its total score, and all of the subscales are added together. And a higher score is indicative of better bowel function, and it has been shown to be correlated with the fecal quality of life. The Low Anterior Resection Syndrome Score is a newer score put out in 2012. It assesses 5 main issues: incontinence for flatus, incontinence for liquid stools, frequency, clustering, and urgency. A higher score indicates worsening symptoms. So 0 to 20 is no Lars, 21 to 29 is minor Lars, and 30 to 42 is major Lars. They've also, the same group that came up with the Lars score recently published normative data for people that haven't had proctectomy. And the group of 50 to 79-year-olds, 18.8% of females actually score a major Lars, and 9.6% of males have a major Lars. So this is important for comparison. Risk factors for Lars are based on various studies, but there's some concern about selection of anastomotic technique as a certain risk factor, the total mesorectal excision versus partial TME, receiving neoadjuvant radiation or postoperative chemotherapy, a very low anastomosis, or even use of a diverting ileostomy has been correlated to increased risk of Lars. These are the various options for reconstructing a colorectal anastomosis. So it's straight colorectal. What happened? Colonic J-pouch, transverse coloplasty, or side-to-end anastomosis. In 2007, this study came out looking at functional outcome, quality of life, and complications for low rectal cancers. They looked at 2 main randomized groups, so a J-pouch ineligible group, so patients with a high BMI or a very bulky mesentery or narrow pelvis, and then patients that were in a J-pouch eligible group. The J-pouch ineligible group was randomized to a transverse coloplasty or straight colorectal anastomosis, and the J-pouch eligible group had a colonic J-pouch, about 5 to 6 centimeters in size, versus a transverse coloplasty, and patients were followed at 4, 12, and 24 months. Total number of daily bowel movements decreased for all groups over time, but there was a significantly lower amount in the J-pouch group compared with the transverse coloplasty group. The transverse coloplasty group had no significant difference compared with the straight colorectal anastomosis. But you can see that the coloplasty versus straight group really had no difference in any of the following parameters. And the coloplasty versus J-pouch group, the J-pouch had better function in terms of total daily bowel movements, nocturnal bowel movements, pad usage, which was durable up to 24 months, Fizzy score, and clustering of bowel movements. A more recent study came out randomizing people to a side-to-end anastomosis, colonic J-pouch, or straight colorectal anastomosis. This was a prospective randomized multi-center trial. They used composite evacuation score as primary endpoint, and they found no significant difference in morbidity, mortality, recurrence, or survival for all three groups. Here you can see the composite evacuation score were pretty similar for all three groups. There are no significant differences at any time point. And same for the composite incontinence score. So these authors concluded that colorectal anastomotic technique should be based on surgeon preference and technical ability, and that the colonic J-pouch is not the answer to everything. As you can see, there's conflicting data from the literature. Other studies have shown improved function with the colonic J-pouch, but only in anastomoses less than 4 centimeters from the anal verge. Moving on to treatment options, there's various levels of treatment, so dietary modification or medications, transanal irrigation or enema training, biofeedback therapy, sacral nerve stimulation, and colostomy creation. So in patients with clustering or diarrhea symptoms, bulking agents may be helpful, Imodium or Lomodal as well. And for patients with overgrowth or bloating, they could undergo lactulose breath testing, and if there's concern for bacterial overgrowth, rifaximin may be tried. Serotonin receptor antagonists is another medication that has been suggested to help with patients with urgency or incontinence symptoms, or patients with a strong postprandial reflex, as serotonin plays a key role in initiation of peristalsis. Biofeedback therapy can also be very helpful in outlet dysfunction and can improve incontinence and sphincter pressures and quality of life, but existing studies are very, very small. And sacral neuromodulation has been shown in small studies that fecal incontinence and ability to defer defecation has been improved, especially in Lars patients. In DCNR in 2016, this treatment algorithm was suggested that after surgery, patients can begin pelvic floor muscle training and or Kegel home exercises. If they're going to have a delayed stoma closure, such as our patient who had chemotherapy afterwards, they could perhaps trial antegrade enema training. For patients after surgery that have had their stoma closed and have severe Lars, they could try retrograde irrigation or enemas, pelvic floor rehab, biofeedback. Patients with symptoms that we discussed with postprandial reflex or gas or bloating or soiling could try medical options. After 1 year, if patients have continued severe Lars, sacral neurostimulation should be considered. And after 2 years and severe Lars and a low quality of life, a stoma may be recommended. So in conclusion, we talked about our patient. Did she have Lars? Yes, she was a post-proctectomy patient with changes in her bowel function affecting her quality of life. What were her risk factors? She received neoadjuvant chemoradiation. She had total mesorectal excision. She had a diverting ileostomy with some delayed closure before it was reversed. She also underwent postoperative chemotherapy, and she had a low anastomosis, which was also a straight colorectal anastomosis. What can the patient expect for her future? She may continue to improve for the first 6 to 12 months, but if not significantly improved, these changes may be permanent, or she may be a candidate for other treatment options, such as sacral nerve stimulation or stoma creation. So in summary, low anterior resection syndrome is common after proctectomy. Fecal incontinence, increased stool frequency, clustering of bowel movements, and difficult evacuation are the most common symptoms, and symptoms may resolve or improve with time or can be persistent for years. The colonic J-pouch possibly offers improved outcomes in the short term. However, this is not consensus opinion in the literature. Current treatment options include dietary modification, biofeedback therapy, sacral neuromodulation, and stoma creation is a possibility for refractory Lars.